Welcome to the deep dive. We've received a lot of material from you about Dr. Jason Fung's perspective on type 2 diabetes. And honestly, some of it offers a really different take. So we've gone through that information, and our mission today really is to pull out those key insights.
Yeah, the crucial bits.
And maybe some of those aha moments for you, the listener.
Exactly. We're trying to look beyond, just the typical focus on high blood sugar.
Right.
And dig into this argument that type 2 diabetes is, at its core, it's about insulin resistance. And also having too much insulin circulating, hyperinsulinemia.
Okay.
The main idea here is that this happens because our cells, they sort of get overloaded, filled up with glucose and fat.
Like tiny storage units just packed full.
That's a good way to put it, yeah. Completely full.
And the material suggests this isn't like a minor thing, is it?
Yeah.
It sounds like it can affect almost the entire body.
Oh, absolutely. According to this perspective, it's potentially impacting nearly every single organ. It's presented as a truly systemic issue. And so, starting from that understanding of the root cause, we'll explore the proposed solutions.
Which lean heavily on diet.
Yes, very much so. We'll be looking at low-carbohydrate approaches and, maybe most interestingly, intermittent fasting, how these might tackle those underlying problems.
All right, let's dive into that core problem then. Insulin resistance and hyperinsulinemia, this overflow phenomenon. Can you maybe unpack that a bit more for us?
Sure. So think about it like this. Your cells, they need glucose for energy, right?
Right.
And insulin is the hormone, the key, that lets glucose get from your blood into the cells.
Okay.
But if you're constantly sending too much glucose and fat into the system, more than your cells can actually use or store properly, they start to fill up. And eventually they become resistant to that insulin signal. It's like the key doesn't quite turn in the lock anymore because the room inside is just jammed full.
Like trying to shove more clothes into a suitcase that's already bursting at the seams.
Exactly that. And here's where the cycle really kicks in. Because if the glucose can't get into the cells easily, it stays in the bloodstream. That leads to high blood sugar.
Right, which is what we typically measure.
Precisely. But the body's response, it's to pump out even more insulin. It's trying harder and harder to force that glucose into those resistant cells.
So that's the hyperinsulinemia part. Too much insulin.
You got it. And this creates a vicious cycle. One of the sources puts it very plainly. More insulin leads to more resistance, and more resistance leads to more insulin.
It sounds like shouting louder when someone can't hear you doesn't fix the hearing problem.
That's a perfect analogy. And this excess glucose, it doesn't just float around. Your liver gets involved.
Okay, how so?
Through a process called de novo lipogenesis, DNL for short.
De novo. New fat creation.
Pretty much. New fat creation in the liver. If there's too much glucose around, the liver starts converting that extra sugar into fat.
And that leads to fatty liver.
It certainly contributes to it, yes. And fatty liver, in turn, actually makes insulin resistance worse.
Oh, wow.
Yeah, the material really highlights this connection, saying something like, while type 2 diabetes is considered primarily a disease of excessive insulin resistance, it actually represents two separate physiological defects. First, insulin resistance, an overflow phenomenon, is caused by fatty infiltration of the liver and muscle.
So it's this whole complex interplay, excess sugar, excess insulin, fat being made where it shouldn't be, all feeding back on each other.
That's the picture painted, yes. It's not just one simple thing.
Okay, now let's talk about the consequences. The source material was, quite blunt about the potential damage.
It really was. It argues that high blood glucose, sustained over time, isn't just a number. It can cause damage to almost every part of the body.
Yeah, the phrasing used was pretty shocking. Every cell in the body starts to rot. That paints a grim picture.
It does, and it's meant to emphasize the seriousness, I think. The potential for widespread long-term damage if the root causes aren't addressed.
So what kind of damage are we talking about specifically?
Well, the sources list quite a few potential complications, essentially hitting the body from head to toe. Things like blindness, described as the eyes rot, kidney failure, maybe needing dialysis, kidneys rot, heart attacks, heart failure, heart rots, even links to Alzheimer's brain rots.
Goodness.
And it continues. Fatty liver progressing to cirrhosis, liver rots, diabetic foot ulcers, legs rot, and nerve damage or neuropathy nerves rot.
It really drives home how systemic this can be.
Absolutely. And it's pointed out that diabetic kidney disease, nephropathy, is actually the #1 cause of end-stage renal disease requiring dialysis in the U.S.
That's a staggering statistic. Really puts the scale into perspective.
It does. Now, shifting gears slightly, let's look at why the author thinks some common treatments might be missing the mark.
Okay.
The argument presented is that many conventional methods focus primarily on lowering the blood glucose number.
Which sounds like a good thing.
Well, yes, lowering high blood sugar is important, but the critique here is that they don't necessarily address the underlying problem, the body being overloaded with glucose and the resulting insulin resistance.
Right. I remember a quote about that, something about medications like insulin or metformin.
Yes, exactly. The source says something like, these drugs lower blood glucose, but these drugs do not rid the body of excess glucose. Instead, they simply continue to take the glucose out of the blood and ram it back into the body.
Ram it back into the body.
Yeah, the idea being it gets pushed into other tissues, potentially organs that are already struggling, which might just shift the problem around, not solve it. The underlying problem, of course, is unchanged.
That's a really strong critique of standard practice.
It is, and it touches on the history, mentioning that while insulin was a lifesaver for type 1 diabetes, its role in type 2, where resistance is the key issue, is, well, seen differently in this perspective. It didn't solve the fundamental problem for many.
Did the author mention other common diabetes drugs too?
Briefly, yes.
Concerns were raised about classes like sulfonylureas, TZDs, and DPP-4 inhibitors.
What kind of concerns?
Things like potential weight gain, questioning the long-term benefits beyond just lowering blood sugar numbers, and again, that core criticism of focusing on symptoms rather than the root cause, the cellular overload and insulin resistance.
So the overall theme seems to be, if the cells are full, treatments that just try to shove more in might not be the best long-term strategy.
That's the essence of the argument presented, yes.
Okay, so if medications alone aren't viewed as the complete answer here, where does this perspective point us? It sounds like diet is key.
Absolutely, diet is central. Specifically, the role of carbohydrates and sugar.
How so?
Well, the material explains how carbs break down into glucose. It mentions concepts like glycemic index and load ways to gauge how foods affect blood sugar.
Right.
But the real emphasis is on excessive amounts of refined carbohydrates and sugar, especially fructose. These are singled out as major drivers of that liver process we talked about, DNL.
De novo lipogenesis, the new fat creation. Exactly. The source explains that too much glucose and the high insulin that follows signals the liver to really ramp up fat production.
And if the liver makes fat faster, then it can ship it out.
Then it starts accumulating right there in the liver, leading to fatty liver disease, which, as we said, worsens insulin resistance.
Is there evidence for this?
The source mentions a study where people eating sugary snacks for just 3 weeks showed increased liver fat and signs of liver damage.
3 weeks? That's really fast.
It suggests a pretty direct and rapid impact, yeah.
And it's interesting, this perspective seems to flip the script on dietary fat a bit. It suggests carbs are the main issue for raising saturated fat in our blood, not necessarily the saturated fat we eat.
That's a key point made, yes. The idea is that consuming excess carbs leads the body to create saturated fat via DNL. This view challenges the more traditional focus on limiting dietary saturated fat intake as the primary way to control blood levels of it.
Okay, so if high-carb, high-sugar diets are framed as the problem,
then the proposed solutions naturally involve dietary changes aimed at lowering insulin.
which brings us back to low-carb diets and intermittent fasting.
Precisely. Low-carbohydrate, healthy fat, or LCHF diets and intermittent fasting are presented as the main strategies.
Why those specifically?
Because they both work to effectively reduce insulin levels. And by lowering insulin, the thinking goes, you can trigger weight loss and potentially even reverse type 2 diabetes. There's a direct quote. Both intermittent fasting and low-carbohydrate, healthy fat, LCHF diets effectively reduce insulin and thus can cause weight loss and reverse type 2 diabetes.
And between those two, does the source suggest one is more potent?
It seems to lean towards fasting as perhaps the most direct and efficient way to lower insulin.
Boy, that.
Simply because you're stopping the intake of glucose altogether for a period. This gives the body a clear break, allowing insulin levels to drop significantly and forcing the body to use up its stored reserves.
Okay, this feels like a good point to really dive deep into intermittent fasting itself. It seems central to this whole approach. What exactly is it?
Well, at its simplest, intermittent fasting just means intentionally creating periods of time where you don't eat, extending the natural time between meals or snacks.
Right.
And the source is quick to point out this isn't some radical new fad. It's described as possibly the oldest dietary therapy known.
Really? Older than low carb?
Arguably, yes. The material mentions Dr. Joslin, a prominent diabetes doctor back in 1916, talking about its benefits. And there were observations during World War I and II food rationing in Europe, where populations inadvertently fasted more, and there was a noticeable drop in diabetes mortality rates.
Wow. So historical precedent. But how does it actually work physiologically, according to this view?
It ties right back to that core issue. Too much sugar in the system. By fasting, you stop putting sugar in.
Makes sense.
This forces your body to switch fuel sources. It has to start burning through its stored energy. First, it uses up glycogen, which is stored glucose, mostly in the liver and muscles.
Okay.
And once that's depleted, it turns more significantly to burning stored body fat.
And the key is the insulin drop.
Exactly. Insulin levels fall sharply when you fast. And since high insulin drives fat storage and insulin resistance, these periods of low insulin allow the body to become more sensitive to insulin again.
So it helps reverse the resistance.
That's the idea.
Yeah.
Plus, fasting helps burn off that problematic fat stored in organs like the liver and pancreas, the ectopic fat. This is seen as crucial for improving insulin sensitivity, sometimes even before significant weight loss occurs.
Now, the source draws a really sharp contrast between this intermittent fasting and just standard calorie cutting, the whole eat less, move more mantra.
Oh, definitely. It's quite critical of continuous daily calorie restriction. It cites a very high failure rate, something like 99.5%.
Why so high?
The argument is twofold. One, constantly eating less makes you hungrier. Two, it can trigger your body to slow down its metabolism, that infamous starvation mode.
Making it harder and harder to lose weight.
Exactly. Intermittent fasting, however, is presented differently. It achieves the low insulin state needed to burn fat, but without necessarily causing that metabolic slowdown.
So it doesn't trigger starvation mode in the same way?
Apparently not. Some research mentioned even suggests it might maintain or slightly increase basal metabolic rate. And there's another interesting point about muscle mass.
What about it?
Fasting seems to be much better at preserving lean muscle compared to just calorie restriction. The source claims it's about 4 times better.
4 times? That's significant for body composition.
It really is. It suggests a different metabolic response altogether.
It definitely challenges a lot of conventional weight loss advice. Now, the source included some powerful examples, didn't it? Case studies of people using fasting.
Yes, and these really illustrate the potential impact. For example, there was Simon. He combined a low-carb, healthy fat diet with 3 24-hour fasts each week.
And the result?
He managed to stop all his diabetes medication and got his A1C down to 5.9%, which is in the non-diabetic range.
Incredible. Any others?
Yes. Bridget's story was also striking. She started with a longer 21-day fast.
Wow, 21 days.
Yeah, pretty intensive. But she was able to stop a very high dose of insulin, 210 units daily, plus all her other meds. Then she maintained with 24 to 36-hour fasts every other day.
And her results?
Better A1C, 6.8%, and she lost 63 pounds.
Amazing. It sounds like different schedules work for different people.
Absolutely. Sybil used alternating 24 and 36-hour fasts with low carb, stopped insulin in 2 months. Ravi used 36-hour fasts 3 times a week, stopped insulin in 2 weeks. Elena, similar schedule, stopped metformin quickly, even blood pressure meds later. Richard used 24-hour fasts 3 times a week, off insulin in a month, all oral meds in 6 months, improved kidney markers too.
So consistent results across different patterns.
And Lana started with a 7-day fast, stopped all meds that week, then maintained with 42-hour fasts a few times a week. Lost weight, good A1C after a year. The pattern is pretty clear. Combining fasting, often with low carb, led to significant medication reduction or cessation and improved markers.
It really suggests flexibility is key. What kinds of regimens are generally suggested?
Yeah, the message is there's no single right way. Find what works for you. Examples given include those 3 30 to 36-hour fasts a week, often on alternate days, with low-carb eating on the other days.
Or maybe less intense options.
Sure, like doing 24-hour fasts maybe 2 or 3 times a week, or even just starting with 16-hour overnight fasts most days of the week, basically skipping breakfast or dinner.
And there are different types of fasts.
Yes, it mentions water-only fasts, but also modified fasts, allowing small amounts of fat, like in coffee, or using bone broth, which might make it easier for some people.
And the time it takes to see results can vary.
Definitely. Depends on the person, how strict they are, the regimen intensity. The source does suggest that if results stall, intensifying the fasting, maybe longer duration or more frequency might be needed.
Okay, this is absolutely crucial now. Before anyone listening even thinks about trying this, what are the warnings, the safety consideration?
Paramount importance, yes. The source is extremely clear on this. You must talk to your doctor before starting any kind of intermittent fasting.
Especially if you're on medication.
Absolutely critical, yes. Particularly for people with diabetes taking insulin or drugs called sulfonylureas.
Why those specifically?
Because fasting dramatically lowers blood sugar needs. If you take your usual dose of these meds while fasting, you risk severe hypoglycemia, dangerously low blood sugar. It can be life-threatening.
So medication adjustments are essential.
Essential and must be done under medical supervision. You'll likely need to monitor your blood glucose much more frequently, maybe several times a day, especially at the start.
The doctor helps figure out how to adjust the meds.
Yes. They can advise on reducing doses or even temporarily holding certain medications during fasting periods to prevent lows. The goal is to use the minimum needed while fasting. If you go too low, you have to eat sugar, which breaks the fast.
Makes sense. Any other medication points?
Just that some other non-diabetes meds or supplements might need to be taken with food, so that needs discussion with your doctor too. Adjustments might be needed there as well.
Okay, doctor consultation is non-negotiable. Are there other side effects people might experience when starting out?
Yes, there can be an adaptation period. Some people might feel hungry, get headaches, maybe muscle cramps, or even notice some skin changes.
Is that normal?
It's often described as part of the body adjusting, maybe detoxifying, or getting used to burning fat. These usually settle down within a couple of weeks.
Now, what if you feel really unwell?
The advice is clear. Stop fasting immediately and seek medical advice. Always err on the side of caution. Listen to your body.
Good advice. And quickly, what was that dawn phenomenon thing again?
Yes. That's when your blood sugar might be a bit higher in the morning after fasting.
Which sounds counterintuitive.
It does, but it's explained as a normal hormonal process. Hormones released overnight can cause the liver, especially a fatty liver, to release some stored glucose.
So it doesn't mean fasting isn't working.
Not necessarily. It could actually indicate that your body is accessing and releasing that stored sugar, which is part of the goal. It usually doesn't require treatment unless it's excessively high.
Interesting. Okay, so beyond diabetes, the source heavily links intermittent fasting to weight loss too. How does that work?
It's the same core mechanism, really. Lowering insulin. By fasting, you lower insulin levels, which signals your body to stop storing fat and start burning it.
Simple as that.
Essentially, you shift from burning the food you just ate to burning the energy you have stored glycogen first, then body fat. High insulin promotes fat storage. Low insulin allows fat burning.
And again, this is contrasted sharply with just cutting calories constantly.
Yes, the same points are reiterated. Calorie restriction often leads to more hunger, slower metabolism, high failure rate. Intermittent fasting is presented as hormonally advantageous, lowering insulin, potentially boosting metabolism slightly, making it easier to access and burn stored fat.
Is there evidence fasting is better for weight loss?
The source cites studies suggesting alternate day fasting led to more weight loss, especially more visceral fat loss, and better muscle preservation compared to just cutting calories daily.
And the case study showed weight loss too.
Oh yes. Simon lost 45 pounds, Lana 55 pounds, Alberto 24 pounds in just 3 months. Significant weight loss was a common outcome alongside the diabetes improvements.
And the recommended fasting schedules for weight loss are pretty much the same.
Yes, things like 24-hour fasts a couple of times a week or 16-hour daily fasts, often combined with that low-carb, healthy fat diet for a synergistic effect on lowering insulin.
And the big caveat remains.
Talk to your doctor, especially if you have any health conditions or take any medications. Safety first, always.
I got it. Now let's dig a bit more into the metabolism side. It's not just about calories in, calories out here.
No, it's presented as a metabolic switching mechanism. When you fast, your body changes its primary fuel source.
From glucose to
Stored energy. First glycogen, then increasingly body fat.
And hormones drive this switch.
That's the key, insulin drops. But other hormones change too. Noradrenaline can increase, which helps keep metabolism up. Growth hormone also tends to rise during fasting, which is thought to help preserve muscle mass.
So that's how it avoids the starvation mode metabolic slowdown.
That's the argument. Unlike chronic calorie restriction, where the body might slow down to conserve energy, fasting allows access to huge reserves of stored energy body fat. So the body doesn't need to slam the brakes on metabolism.
It has fuel readily available.
Exactly. It can keep the engine running by switching fuel tanks, essentially. Some studies even show a temporary increase in metabolic rate during short-term fasting.
You mentioned the Randall cycle earlier. How does that fit in?
Right. The Randall cycle basically describes how your body chooses which fuel to burn, fat or glucose. During fasting, the body preferentially burns fat
Why?
to save the limited glucose primarily for the brain, which relies heavily on it. Though the liver also starts making ketones from fat during fasting.
Ketones.
Yeah, they're an alternative fuel source the brain can use very efficiently, further reducing the need for glucose during prolonged fasting. It's an adaptation for periods without food.
Clever system. Now, what about physiological insulin resistance? That sounds bad, but you said it's different.
Yes, it's important to distinguish. This is a temporary state. If your body has been burning fat for a while, due to fasting or very low-carb eating, your cells become really good at using fat. If you then suddenly eat a bunch of carbs, your cells might be a bit slow to switch back to using glucose, leading to a temporary spike in blood sugar.
So it looks like insulin resistance, but it's not the chronic kind.
Exactly. It's not the same as the underlying problem in type 2 diabetes, where cells are chronically resistant. This physiological resistance usually resolves quickly as insulin rises, and the body adapts back to using glucose. It's just a temporary fuel use adjustment.
Got it. One more point the source brought up was waist circumference versus BMI. Why is waist size seen as more important here?
Because waist circumference is a much better indicator of abdominal fat, especially that deep visceral fat around the organs.
And that's the dangerous kind.
It's considered much more metabolically harmful, yes. Strongly linked to insulin resistance, type 2 diabetes risk, heart disease, all those things. BMI doesn't tell you where the fat is.
Right. You could have a normal BMI, but still have a lot of that internal fat.
Exactly. The source calls this TOFI, thin on the outside, fat on the inside. These individuals can be at significant risk despite looking lean. Waist measurement helps catch that.
Which connects directly to metabolic syndrome.
Precisely. Metabolic syndrome is that cluster of issues. Big waistline, high triglycerides, low good cholesterol, HDL, high blood pressure, all tied together by insulin resistance.
And fatty liver fits in there too.
Yes. Fatty liver is often one of the earliest signs, developing alongside or even before the other components of metabolic syndrome become obvious. It's all interconnected.
Okay, so let's try and wrap this up. If you had to summarize the absolute key takeaways from this deep dive into Dr. Fung's perspective, what would they be?
I'd say the core message is reframing type 2 diabetes, seeing it not just as a high blood sugar disease, but primarily as a disease of too much insulin, hyperinsulinemia, and insulin resistance.
Driven mainly by diet.
Driven largely by diet, according to this view, especially excessive refined carbs and sugars filling up our cells. This perspective critiques treatments that just lower blood sugar without addressing that overflow.
And proposes dietary solutions.
Yes, strongly advocating for low-carbohydrate, healthy fat diets, and perhaps most powerfully, intermittent fasting as ways to directly lower insulin, tackle that root cause, burn stored energy, and potentially reverse the condition.
But, and we have to say it again, the absolute necessity of talking to your doctor before making any big dietary changes, especially if you're on medication.
Cannot stress that enough. It's crucial for safety, particularly with diabetes medications, where the risk of hypoglycemia during fasting is very real without proper medical guidance and adjustment.
Absolutely. Okay, so here's a final thought for you, our listener, to consider.
Yeah.
If this perspective holds weight, the idea that dietary changes like intermittent fasting can fundamentally address type 2 diabetes by tackling insulin resistance. What does that mean for our broader public health approaches?
Yeah. What are the implications for official guidelines for how we typically treat diabetes? And maybe what other deeply ingrained ideas about diet and health might need a second look based on this kind of thinking?
Definitely something to mull over. Thanks for joining us for this deep dive.